at the end of the session. So just a little bit on pediatrics versus adults. Pain tolerance and pain perception is going to be a little bit different for kids. They're not going to understand what exercising feels like and the pain that you would normally have after exercising. So you want to try to explain what good pain and bad pain is to them. Body weight versus weight training. So body weight is going to be something like a push-up or a wall sit. And weight training is going to be using dumbbells. We typically try to use body weight for kids. And then when they start to get older past puberty, that's when we start to use weight training. And then the most important part for kids is that you need to make it fun. If they're not having fun, they're not going to do it, and they're not going to get better. So just to talk a little bit about good pain and bad pain. We'll start with good pain. It usually lasts less than 48 hours. It's usually going to feel a little bit dull and achy. It's going to get a lot better with rest. It's going to get worse if you do too much activity. And just to talk a little bit about sore muscles and what it feels like to be sore afterwards, a lot of people who have never exercised before will confuse being sore with pain. And so we want to kind of just differentiate between being sore and actually being in pain. Bad pain is going to last more than 2 days. It's going to feel more sharp and shooting. It's going to get worse with rest. And you can also have pain with sleeping, and that's considered bad pain. And then for patients with CRPS, it's going to stay above your baseline. So a lot of you, and we'll talk about pain scales in a couple minutes, but a lot of you will say, well, my pain is a 7 out of 10 normally. So bad pain is going to be something that's above that 7 out of 10. Typical exercise guidelines for all healthy individuals is greater than 30 minutes of moderate activity most days of the week. There are scales to measure what moderate is, and I'm going to talk about those next. There's also pain associated with exercising. Again, we talked about the good pain versus the bad pain. Especially with CRPS, there is going to be some level of pain associated with exercising, and that's okay. This first scale here is the RPE chart. It's the rate of perceived exertion. It's different for every person. It goes from 1 down at the bottom, which is very light, like you're not doing anything, and goes all the way up to 10, which is your max effort. And most people are not going to 10 unless they're competing in some sort of a high-level race or exercise. We typically try to tell people to stay in the 4 to 6, maybe 7 to 8, especially with physical therapy and general strength training and exercise. Everybody's own perception of that scale is going to be different, and that's what's nice about this scale here. Pain. It can be really hard to qualify and quantify what your pain is and to describe that to somebody else. I have some really good charts that are very useful in explaining the higher levels of pain. It's typically on a scale of 0 to 10, 0 being no pain, 10 being the worst pain imaginable. For everybody with CRPS, 10 is going to be different, and you're going to go past 10. So I'll show you the scale for that. A lot of patients with CRPS will function at a 7 out of 10 on a daily basis. So for somebody without CRPS, a 10 is a lot of pain, and they probably wouldn't be functioning. Somebody with CRPS, they're already functioning at a 7 out of 10. So we've got to think about what's higher than that. And we reestablish that scale. So this is a good scale to use for kids. Because of the smiley faces, it helps kind of break down what the numbers actually mean. This one I know is used in hospitals a lot too, especially if people can't verbalize what their pain is. The next one uses a little bit more of a color scheme, and it does give you some words as to what the numbers kind of correlate with, and that's going to be more of your typical scale. This next one is, I know it's really hard to read. The presentation will be up online afterwards. This is really good for people that are in a lot of pain, and it helps to kind of explain what each level means. And then this one is the McGill pain scale. You see at the bottom there is, the bottom line is going to be 0. 10 is going to be what we've been talking about, 0 to 10. And look how much higher it goes, up to 50. So you look at a bruise or a fracture, it's way down here. Childbirth, right about there. And now CRPS is going to be up so much higher than everything else. So this next scale is really nice. Again, sorry, the typing is small, but we have your 0 at the bottom. This is your standard scale up to 10. And now we're talking about kind of that 6 to 7 area of that normal functioning. We bring it over to that's now your 1, and then now we go up to there, up to the top, kind of in different increments, and it's off of the standard scale. Another way to moderate what your exercise is measuring heart rate max. It's based on your age. There's a formula. It's 220 minus your age. That's your heart rate maximum. And then what we typically try to say, just like with the RPE, we're staying between a 6 to an 8. We're trying to stay between 55 to 85% of your heart rate max. So in order to do that, you'd need to calculate what your target heart rate is and then wear a heart rate monitor while you're exercising. It's a good way to correlate your pain levels with your exercise levels so that when you do establish an exercise program, you know, okay, my pain shoots to a 10 out of 10 when my heart rate is this high, so I don't want to get that high. So to talk a little bit about physical therapy and what physical therapy is, kind of as a general rule, it's a rehab program. It's going to restore strength, flexibility, and try to return you to a prior level of function. We also try to reduce pain. There are some nicknames associated with us. So any of you who have been in physical therapy already know physical torturer, physical terrorist. We welcome those nicknames. We're trying to get you better. We're doing what it takes to get you better. You may hate us during the sessions, and then when you finally are starting to feel better, then it's a little bit more of a love part of the love-hate relationship. It's also not a matter of no pain, no gain. Some pain is to be expected, and that's really important to understand that there is going to be some pain associated with getting better, and that's okay. Typically, physical therapy, when you go into a physical therapy office, it's going to follow a typical progression. And especially if you're not already diagnosed with RSD or CRPS, you're going to go in and you're going to have your eval, and they're going to give you a program, and you're going to follow that program for 6 to 8 weeks, and you may or may not get better. And that's kind of where it's tricky, where if you're not already diagnosed, it can be really challenging for the physical therapist. But on the other hand, the PT might be the one to help pick up on the CRPS if it's not diagnosed yet. And if you are diagnosed with it, you need to make sure that your PT is aware of it and knowledgeable on the subject. So patients with CRPS are going to fail traditional physical therapy, and that's important to understand. If your physical therapist doesn't know that you have CRPS, they're going to put you through the typical PT program, and you're not going to do well. You're going to have more pain, you're going to get frustrated, you're going to quit PT early, you're going to have a bad perception of physical therapy. So it's really important to make sure that your PT knows what CRPS is and how to treat it. Some patients with RSD will fail immediately within the first week or so, but sometimes it takes a little bit longer. So within 4 to 6 weeks, if you're not getting better, if your pain is worse, you need to have a conversation with your physical therapist to change something. Again, most PTs should pick up on at 4 to 6 weeks if you're not getting better, something needs to happen. But some may try to press on and say, oh, it's okay, you'll get better, it's okay, you'll get better. It's a waste of your time if you're still at a 6-week mark and you're worse. So when to know when to change what you're doing. If you're not getting better, especially if you're getting worse, and I don't mean worse in a day or 2 days or 3 days. I mean worse overall. So from the first day of physical therapy through to 3 weeks later, if overall you're worse, that's when you want to say something to your physical therapist. Any changes in your symptoms, so it started in your hand and now it's all the way up to your neck, something like that is going to be a sign that you're not getting better. You need to talk to your doctor, talk to your physical therapist, and change the plan of care. So just to give you an idea of what PT involves, every patient will go in for an evaluation. The first visit is one-on-one. It's always with a physical therapist. It's usually 45 to 60 minutes, depending on all of your background history that needs to be given. It's a systems review, medical history, tests and measures, trying to find out what your baseline is at that time. A plan of care is created. You're usually seen in the office 1 to 3 times a week, and you're given homework, and that's really important. You're going to have things to do on your own at home that if you don't do them, you're not going to get better as quickly as you could if you did them at home. PT sessions are usually going to be 30 to 60 minutes. You should always see your physical therapist or a physical therapist assistant, but you will usually see a technician or an aide as well. There should be some sort of manual-based treatment, which means that the PT actually puts their hands on you. There's going to be exercises, and there's going to be modalities, which include ice, heat, electrical stimulation, ultrasound, laser, and dry needling. Just as a kind of idea of general tissue healing, a bone injury usually takes 8 to 12 weeks to heal. And these are kind of guidelines so that when I was talking about if you're not getting better, this is your timeline of if your injury is a bone injury, you're looking at least 8 to 12 weeks before you start to feel better. It doesn't mean you're healed, it just means you're feeling better. So if you're at 16 weeks and you're not even kind of feeling better, it's a good indicator that something is not going right. Sprains, strains usually take 6 to 8 weeks. And then cuts and scars, that's kind of a side note that usually with RSD, they stay cuts for longer and they can have worse scar appearances. Okay, so talking about pain again. Like I said before, it's normal to have pain. It's normal to have an increase in pain. But your physical therapist should bring you down from those pain levels. So in a session, in that hour session that you're in the office, your pain is going to increase, but before you leave, your pain should decrease. It should at least return partway to baseline, if not all the way back down to baseline. And it's really important that you communicate with your physical therapist so that they understand what your pain levels are. Some ideas for pain relief before your session is taking pain meds prior to getting to PT. You know how long it takes for it to kick in, so if it takes an hour to kick in, take it an hour before you get there. The next one is controversial icing. There are studies that say that ice is not good for RSD. So some people like it and some people it works for. I stress that you need to make sure that your dosing of the icing is correct. That no more than 10 minutes for ice to an area. And that's for anybody, regardless of whether you have CRPS or not. I don't necessarily recommend the ice, but if you know you're going to have something done to you at PT that hurts and it helps to numb the area for that session, I don't think it's necessarily a bad thing for that twice a week. Heat to soothe the area helps a lot, and then gels, creams, biofreeze, icy hot, your medications. Discharge from physical therapy. This is important as well. In order for a physical therapist to bill your insurance, it needs to be skilled therapy. And so that's how we kind of decide when discharge happens, is that are we still doing something that's skilled therapy, or is it something that you could be doing at home? Physical therapy is not expected to be long-term. We're not supposed to see you for 6 months, 8 months, a year. That's not the goal with physical therapy. We're trying to get patients to be independent with their home exercise program. It's okay to come back for check-ins. So if you are discharged and a month later things are changing, it's okay to go back in and say, hey, you know, this is changing, can you take a look? And all physical therapists should be okay with you coming back in. Also, don't expect to be 100% and pain-free after your physical therapy sessions. We usually discharge around 80 to 90% of your function and pain less than 3 out of 10. Now again, that 3 out of 10 is going to be different because of those scales. So 3 out of 10 on a 1 to 10 scale. What if my physical therapy doesn't know about CRPS? Okay, there's going to be a lot of PTs that we learned about it in school. We probably learned about it for maybe 10 minutes out of my 6-year career time in school. And so the amount that we're able to be taught during school is not enough to actually just go and treat a patient. You need to educate your physical therapist. My first patient that came in with CRPS had a binder this thick of articles, and she said to me, she kind of gave me all of her history and told me about CRPS, and I had heard about it before. I had treated it a couple times, not necessarily successfully, and so I took the articles home and I read them, and I learned from them, and then together we worked on a program that worked for her. So that's really important don't be afraid to educate your PT on what's going on with your body. You have the right to call every PT office in your area and ask them if they have physical therapists that know about RSD and know how to treat it and have experience treating it. A lot of places, if you call, they're going to say yes because they want you in the door. But you need to make sure that they actually have some experience or are willing to learn about it. Some tips for physical therapy when you do have CRPS. A private room might be helpful. We talked about the pain relief measures pre and post session, putting creams on, heating the area, taking your medication, having tissues available because you're going to be in pain, there's going to be some crying, and that's where the private room is nice. The PT should explain to the patient the pain that's going to be associated with the treatment that day. And you can always have shorter sessions. So we talked about 30 to 60 minutes. Sometimes you might not be able to tolerate more than 10, 15, 20 minutes, and that's okay too. So some different types of treatment during the PT sessions. Desensitization, mirror therapy, constraint induced therapy, typical exercise program, and modalities. Again, I made another disclaimer about trying to come down from your pain by the end of the session. So desensitization, this is a rice bucket, hand in the rice bucket. The idea with desensitization is you're decreasing the pain pathways to the brain. So you're using different textures and you're using it on the tissue to try to get your brain used to having things touching that area. All different textures, silk, wool, loofah sponge, cotton, canvas, you name it and you can use it. Especially things that, like say your sheets really hurt at night when you're sleeping and just the sheet brushing up on it. That's a good place to start with something like that you know is going to be touching your body. You're going to start off with something soft and then you're going to rub it on the area gently and you're going to build up to be rubbing on it more roughly, and then you're going to be using more abrasive materials. The rice or bean bucket is nice, and then a contrast bath will also do the same thing. Contrast baths are also a little bit controversial. It's not for everybody. Again, we talked about ice not being a good option. What I say is that you just need two different temperatures, one warmer water, one cooler water. So you don't necessarily need to use an ice bath and a hot bath, but just having a difference in temperature. The timing of it is going to vary for the patient and what they can tolerate. So you might start off with just 30 seconds and then 30 seconds in the other bucket. And then you try to build up your time as your sensitivity changes. Mirror therapy is another option. This is used a lot in stroke patients. There are studies that say that it works for CRPS and stroke patients. You're using a mirror to trick your body into using the painful body part. You want to make sure that both body parts look the same, so you want to take off any jewelry. If there's any scarring, you want to try and cover that up as well. The brain is going to see the affected side moving and behaving like the unaffected side. So you're basically tricking your brain into moving the body part. You usually want to start with small movements. Sometimes you just start with looking at it because it hurts too much to even move it. And so you're just, in the picture here, it shows you, you can see her hand that's not hurt. Her hand that's hurt is over here without the ball. And her brain sees the mirror image. So she's going to squeeze the ball or move her fingers here so that her other hand her brain is thinking the other hand is doing it as well. You can start with light tapping of your fingers, eventually getting to the point where you are moving that affected side in the same exact fashion as you're moving the unaffected side. So I talked about wiggling your fingers or your toes, making a fist, flattening it out, opposing your fingers, keeping it rested, squeezing a ball, squeezing a towel. So it was first described for the relief of phantom limb pain, which would be somebody who had like an amputation. But it has been proven, like I said, for the treatment of stroke and CRPS. There are studies in the New England Journal of Medicine that prove that the treatment is effective in reducing pain and enhancing motor function. The next type of treatment is constraint-induced therapy. This is also used with stroke patients, just like the mirror therapy. Basically what you're going to do is you're going to constrain the affected limb. Constrain the unaffected limb. And then forced use of the affected limb. So if your right arm is the one that's involved, you're going to tie up your left arm so that you can't use it, so that you're forced to use the hurt arm. The most important part with this is that it's mass practice. So it's not just for the 30 minutes that you go in for your PT session. You're going to do it for a long time throughout the day, 6 hours a day, 10 days straight. That's kind of the protocol that Dr. Taub used. And it's used for, your forced use is for all daily activities, so during therapy and at home. So getting dressed in the morning, eating, preparing a meal, those kinds of things. That's what you'd be constrained for that whole time. Again, you're not going to do this right at the beginning when your pain levels are super high. You want to start to do this once you've started to bring your pain levels down. Different types of restraints: slings, splints, gloves, mitts. You can go as far as a cast. I don't think that's appropriate because you need to be able to take it off. Exercise programs. So for the exercise portion of physical therapy, you are trying to re-educate the muscle and the body part to function the way that it should be functioning. You're trying to strengthen it, and you're trying to prevent re-injury. A typical exercise program for strengthening in the PT world is going to be 3 sets of 10, moderate to heavy weight for strength building, rest between sets, and focus on form. Considerations for CRPS: your pain might limit your exercise ability. You may only get through 1 to 2 sets. You might only get through 5 or 6 repetitions, and that's okay. You might not be able to do the full repetition. So if a bicep curl, you start out with your elbow straight and you bring it all the way up to bent. If that range is too painful, you may start with just a modified bicep curl. And that's where your physical therapist should be making the decisions. You may need to perform it daily at lower repetitions. And like I said, decrease reps, sets, range of motion to help monitor your pain. We talked again about when is it too much: when you have an increase in pain for more than 1 day after a session, when you have a change in symptoms or new symptoms. So the next is some modalities of things that you can do to help decrease your pain. Heat and ice, electrical stimulation, laser, dry needling, massage, and then lotions, gels, and creams. We talked a little bit about ice and heat already. For the ice, again, there's a typo there. It's supposed to be no longer than 10 minutes. Even in somebody who does not have CRPS, there's studies out there that icing for longer than 10 minutes can start to reverse the effects of icing. So you really want to make sure that the timing is less. It will numb the area, but is that a good thing? There's studies that say that with CRPS, icing can start to damage your nerves. Heat is no longer than 20 minutes, and it'll keep the tissue warm and pliable and feel like it's a little bit looser. Electrical stimulation, the most common form that you'll see for pain relief is TENS, T-E-N-S. It's transcutaneous electrical nerve stimulation. It reduces pain centrally and peripherally. It's the little sticky electrodes that you'll place right on your skin. It's modulated by the PT or the patient. There are home units that you can put on and wear throughout the day. And the idea is that it works on the gate control theory of pain. So the best example is if you bang your funny bone on your elbow and you rub it afterwards to make it feel better, you're providing another noxious stimulus over the area that hurts to help get your brain off of the pain. Laser is another treatment option. It's usually called a cold laser. It's light-emitting diodes, and it helps stimulate cell function. It's effective in reducing pain in CRPS. It stimulates healing, alters your cellular metabolism, improves enzyme production, and stimulates tissue proliferation, so tissue healing. It's not available at all PT locations. It's a very expensive device. It's not yet approved by the FDA for healing, so it's not reimbursed by insurance. So any of the places that do use it, they have purchased the unit and they're using it. It's used all over the world. It's just the U.S. is a little bit behind the times, and so it is very effective in treatment. Dry needling is another option. It's a thin monofilament needle. It's actually an acupuncture needle. It's the same thing, but it is not acupuncture. It's a big difference between dry needling and acupuncture. The needle is directed towards a trigger point, the muscle knot, and it helps release the muscle and causes a twitch response. It helps reset the muscle, helps restore normal function to the tissue, and then allows you to use the muscle better afterwards. Again, it's not used by all physical therapists. The physical therapist that does use it needs to go through extra training to be able to do it. It's very painful, but it's very effective. Massage, there are so many different kinds of massage. Swedish deep tissue, sports massage, trigger point release, craniosacral, effleurage, myofascial release, petrissage, and active release technique. Typically, a good rule of thumb is that massage shouldn't increase your pain afterwards, but may cause some temporary soreness. So you might be sore for a day, 2 days, and then the pain should go away. It's important to drink plenty of water and stretch afterwards. I wanted to touch a little bit more on active release technique. P. Michael Leahy is who patented the treatment. It includes the therapist feeling the tissue and performing specific treatment movement patterns to help release the tension of the tissue. So they're usually going to be pressing on a tight area, and then the patient is going to be moving the body part. So, if we were going to do your biceps, you'd press, and then you'd have specific movements. In order to be ART trained, you have to go through rigorous training to perform the technique, and there's actually specific movement patterns. I use the technique, but I can't call it ART because I wasn't trained in ART, but physical therapists will probably use it anyway and just not know what it actually is. And you're kind of modifying the technique. You're not actually using the exact protocol of the movement pattern, but you're still getting the same results. Again, this is also pretty painful, but usually have really good results. Lotion, gels, creams, just a few of them: Icy Hot, Biofreeze, Tiger Balm, magnesium, and then medicated compound creams that are prescribed by your doctor. The main issue with those is they can get to be really expensive because insurance companies don't always cover them. And so that's a really tricky thing to deal with. So if you are prescribed it, make sure you check with your pharmacy before you get it filled, because I've heard stories of it being $2,000. A couple other special considerations about pain. I like to talk about breathing. Breathing is very, very important. And when we're in pain, we forget to breathe all the time. Posture and controlling your edema. So breathing. It helps you relax. It helps increase oxygen to the flow, oxygen flow to the brain, which helps with healing. Like I said, holding your breath when you're in pain is really, really common. And so you might need to tell yourself all the time, all day long, to breathe. And it can usually reduce your pain levels enough to make you calm down a little bit just by breathing. In through your nose, out through your mouth. That's how I always tell people to breathe. Posture is also very important. What happens when you're in pain is your body starts to adapt and starts to create different postures because the brain and the body thinks it's a better place to be. And then your body learns those positions, and then it's actually worse for your body in the long run because your tissue will start to change. Muscles will get tight that aren't supposed to be tight. Muscles will get long that aren't supposed to be long. And it's a vicious cycle to try and come out of that. So you really want to try and maintain proper posture. And then edema control. Pain is associated with swelling. So if you have increase in swelling, you're going to have increase in pain. You want to try and control your swelling, especially if you've done too much, and that'll help bring your pain levels down as well.
Control edema, huh?
Wrapping it, elevating it.
You can't touch it.
Elevating it, yeah.
Or you could feel skin.
Is it good to sleep with your foot elevated every night? Like I have it on, pretty much like my dad built me like this wooden thing to go over my bed, so I can put the sheet over without it touching.
Yeah.
And then I like elevate it every night too, but I don't know, is it good to have it elevated?
Some people will say yes, some people will say no. I don't think staying in that one position is going to be good for you long term. especially if it's going to be months. You know, with a typical injury, if it's 3 or 4 nights, it's like, okay, whatever. But if you're talking about long term, it might not be good to be elevated.
Like over here.
Yeah.
But like I can't lay my foot on the bed.
Right. And so the other thing is it's important to sleep. So whatever it takes to sleep is important. And I'm always, hands down, when somebody says they can't sleep, you need to be sleeping. So whatever it takes to sleep. There's certain positions, like laying on your stomach is not good to be in that position in general for your neck and your back. But if that's the only way you can sleep, then to me that's more important. Everybody's going to have a different opinion on that, though. So if you ask another PT, they might be like, you can't sleep on your stomach. And so, you know, you kind of have to take it for what it's worth.
Well, you have to put like my ankle like right there, like I have to put like a pillow right here, so
Mhm.
my ankle foot doesn't touch the bed.
Right.
It's painful if it does.
Yep.
So it's like I don't know how to, like I always have to have it
Elevated.
somehow, so I'm
Mhm.
not laying on it.
And if you think about it, if you're laying and it's flat and you wake up and now you're more swollen, it's going to hurt more. So if you elevate it while you're sleeping at night and it's less swollen, it might be less painful the next day.
Purple and swollen as soon as I put it down.
Right.
The only thing I found that really works is a vigorous massage.
Mhm.
It hurts,
Mhm.
it's very painful. But
And that's gonna be
relief eventually.
Like the desensitization, yeah. And that might be something you have to do every day when you first wake up in the morning, throughout the day. Yes and no. I mean, there's tons of wrapping techniques you could wrap, but again, if it hurts to have something touching. That might be, it might be something more systemic with that, whether it's medication or fluid intake, things like that. That might be more than just your typical injury swelling. But in a pool would help with as much as you can get under the water. Mm-hmm.
Maybe something I have to ask after, but
Sure.
I was curious about this dry needling specifically for grips, and how I always thought that maybe it could be a treatment that could do possibly more damage than actual
Yes.
help, but I've seen it done
Mhm.
with other pain conditions, and so it's something I was curious about.
So the difficult part is the needle stick and how you respond to a needle stick. They're very thin needles, so that's important. It's not like getting a needle, like blood drawn. Like those needles are much, much bigger than dry needling. And I would say it's probably trial and error. You're going to get some doctors that say don't do it, don't stick yourself with a needle any more than you need to. But again, kind of like we talked about the sleep, you know, if it reduces your pain, is that more beneficial than maybe having a lot of bruising? I've only needled one person with CRPS, and she didn't bruise after I needled her. But she bruises a lot from needle sticks. Every area that you needle is a little bit different. Some areas have more blood capillaries, and so they might be more prone to bleeding. For example, the quad, for whatever reason, there's so many more capillaries that usually if I needle the quad, I get a bruise on a typical patient. So with somebody with CRPS, it might be even worse.
Do you have any articles?
I don't have any specifically. I can pull them up. I do dry needling, and so I've taken all the courses on how to do it. I don't know if there's any that are specifically to CRPS though. They're going to just be dry needling and headaches, or dry needling and low back pain, and it's another treatment option that's slowly starting to be more widely accepted. Acupuncturists are fighting physical therapists right now across the country to try and get us to not be able to do it because we use the same tool.
Yeah, because I've read and seen it in PT,
Mhm.
and I've seen a couple of pain management physicians who are just starting to learn about it.
Yeah.
And I know you guys have done it for a while.
Yeah.
So,
And it's the same as a trigger point injection, but there's no injection. So doctors are doing it all the time. And so if you think about a trigger point injection versus dry needling for a patient with CRPS, I would go with the dry needling because it's not as big of a needle.
sure.
So-
Yeah, and you're injecting different drugs.
Right, exactly. Yeah.
And I've also read studies about its actual needle in the trigger point
Yep.
injection that helps with the rehealing.
Exactly, it's not even the medicine. But in order for doctors to be reimbursed, it has to be an injection. And PTs, again, we bill it as more of a manual treatment than as a code for a. Thank you.